where you'll hear about some updates from our working groups, as well as the coalition's work. We'll also approve the minutes from our last meeting at that time, and we'll invite coalition members to share updates from their own organizations. So with that, I'd like to introduce our speaker today. So Dr. Katherine Clouser is an assistant professor of pediatrics at Hackensack Meridian School of Medicine. She's board certified in pediatrics and pediatric hospital medicine and has published extensive peer-reviewed work throughout the pandemic on COVID-19 in the pediatric population, including outcomes in children and adolescents with multisystem inflammatory syndrome in children. She's the medical director of the Hackensack University Medical Center's COVID Recovery Center. And on a personal note, Dr. Klauser and I worked together for several years while she was here at Rutgers, and I'm really happy to welcome her back, and I'm excited to hear her presentation. So join me all in welcoming her, and we're all ears for your presentation.
Thank you so much for having me. And as Dr. Schwab said, I trained in Essex County, so I've got a special place in my heart for Essex County children and for the health of Essex County children. So I'm happy to be here to present to all of you. I'm gonna go ahead and share my screen here and we'll get started. I tried to kind of target this presentation toward a variety of audiences. So there may be some things that are pretty simple, maybe not so simple. So, and please put questions in the chat. If you have questions, I should have time at the end to discuss questions. These are the disclosures that Emily already went over. I have no disclosures, no financial kind of interests. So my learning objectives, we're going to talk about the clinical features of pediatric COVID-19, discuss vaccine safety and indications, understand a little bit of the long-term sequelae of COVID-19, and discuss sports clearance for patients after infection. I also put a little in at the last minute about some treatments because I think that that's a really valuable piece that's kind of new and upcoming in the information that we're gathering kind of every day. So we'll start with acute COVID-19, which is a little bit different than some of the other kind of post-COVID sequelae. This is as of Sunday, as of March 20th, 2023. These are all of the cases, not just children, but these are all the cases in Essex County. And part of why I really like this screen. So first of all, in Essex County, there have been over 193,000 positives. And what I really like is you get this nice idea that there were 3 peaks, with the most recent being the highest in peaks, right? So in Essex County, most recently with Omicron, we had a large increase in cases, and this is just PCR positive. So these are not necessarily hospitalized, but you can see very nicely that New Jersey kind of followed, I always joke, New Jersey followed the book and really went through these peaks that were expected. For children in terms of clinical features, and again, it's a little bit difficult, sorry, to go back to this slide to really tease out exactly how many are under 18, but the under 18 has also peaked in this exact same, if you look across the state of New Jersey, with kids seeming to get more Omicron than they did any of the other variants. When we look at acute COVID-19, this is specific to New Jersey. We did a study of New Jersey hospitals kind of throughout both in northern, southern, and central New Jersey, looking at how kids actually presented with acute COVID-19. Most children are going to be mildly symptomatic or asymptomatic, but fever, cough, and shortness of breath is far and away the most common, with fever, cough, and shortness of breath kind of being a spread there. The reason why I think shortness of breath is a little bit less reported is it's very difficult for a 4-year-old to tell you that they're short of breath, but they can tell you that they have a cough, and the parents are measuring this fever. This did change a little bit with Omicron. There was a little bit less of fever, but definitely cough was still present. Then you have patients reporting myalgias, rhinorrhea, sore throat, headache, nausea, vomiting, abdominal pain, diarrhea, and loss of smell or taste. The loss of smell or taste also was probably underreported. Again, it's difficult for a 2- to 3-year-old to tell you whether they are losing their smell of taste. And then with Omicron, there was less of this as a clinical presentation as well. Sore throat tended to become kind of a broader symptom that patients were having, and that's true in adults and children. So this is specific to those less than 18, what they were kind of experiencing throughout the first 2 waves of infection. There was some variance. Seemed like the early variants seemed to spare children, but as we're all well aware, part of that is because children were not doing anything that they had been used to doing. So early on in the pandemic, we stopped school, stopped sports, stopped everything. And children were not the ones going grocery shopping. They were not the ones who still had to go to work. So they really seemed to be spared. And anyone who works in a hospital noticed that we really were spared all childhood illnesses. We really stopped seeing kids, to the point that I'm a pediatric hospitalist here at Hackensack, and I started to take care of patients up to age 45. So I was caring for adults because we just didn't have the population of children who were needing care. Those who were infected and who were hospitalized, it was primarily gastrointestinal symptoms. So for the first wave, we saw a lot of just really bad diarrhea requiring IV fluids, but they were not having the severe respiratory infections that we originally saw in with other patients. In fall of 2020, more patients were admitted with respiratory illnesses. And kind of needed oxygen. It was more like the typical viral bronchiolitis that you would see, but it was in older patients. So we were seeing that in teenagers. And then with Omicron, we had a large increase in the infection rate. And you saw that peak on the first graph that I showed. Sore throat did seem to be a predominant symptom. And we did have a corresponding increase in hospitalizations, but it was often just for dehydration, or one thing that we do talk about is with COVID, not for COVID. So we did have an increase in January, February, and March in all the hospitals in New Jersey of children who were hospitalized with COVID-19. And that's partially just because the number of sheer infections was larger. The percentage did not change. It's still a low percentage of patients that will need hospitalization with COVID-19. But the other thing that changed is that kid who broke his leg also was incidentally COVID positive, where we had a large increase. And I'm sure everyone who works with children, and particularly those of you who are school health professionals, know that psychiatric illnesses definitely increased during this time. And a lot of patients were admitted with COVID. They happened to be incidentally positive as opposed to for COVID. And we are seeing that kind of increase as we analyze the population. There are treatments available. I think that this is a really important slide. It's a little bit wordy. Part of the reason I put it all on here is that I know you guys are going to get this slide, so it's a good place to reference back to. So most patients are just going to require supportive care. The same thing that we have been doing as pediatricians for years and years and years, which is just kind of allow them to get better. And I do think that this is why pediatricians did such a great job caring for COVID patients. My length of stay in a 45-year-old was 3 days, and the adult's length of stay was about 7 days. It was a really fascinating kind of trend that we saw. And part of that is because I'm used to seeing viral infections, right? That is what everybody here on this call does all the time. Everyone has a cold, everyone has something. And so supportive care and just kind of watching and waiting and allowing them to get better with a little bit of IV fluids and a little bit of oxygen was a really natural thing that happened. Whereas in the adult world, there's not a lot of just supportive care that happens. So most patients will just require supportive care. We do still use remdesivir. It's recommended for hospitalized children who are over 12 years, who have risk factors for severe disease and need supplemental oxygen, or those who are over 16 and who need oxygen, whether or not they have risk factors for severe disease. So what that means is anyone over 16 who's on oxygen is going to get remdesivir. Any 12-year-old who maybe has asthma or obesity or some sort of chronic illness will also qualify for remdesivir under the EUA, the emergency use authorization, if they're needing oxygen. What remdesivir is it's an antiviral drug, and it has shown to decrease hospitalization length of stay. It's by about 2 days, really kind of 1 to 2 days, it decreases the hospitalization. And so we're continuing to use it. It was used very heavily early on because it was the first drug that we had that was making any dent in the hospitalization, and we really needed those beds in those times. But incidentally, I think that it's going to become less kind of helpful in children, but currently we're still using it. What has been really beneficial has been dexamethasone. Dexamethasone is used in patients requiring oxygen therapy regardless of their risk factors. And the risk factors for severe disease are pre-existing lung, you can see it kind of all there, pre-existing lung diseases, obesity, any other chronic illness, they're going to have an increased risk for severe disease. But the dexamethasone, Decadron, was actually used, and it's really helping quite a bit. They get the dose, their inflammation kind of calms down, and it does seem to decrease their oxygen burden. We now have monoclonal antibodies as a choice and as an option, and this is in patients who are over 12 years of age. It's a subset of patients, and monoclonal antibodies are used prior to hospitalization. You want to start it within 7 days of infection. any severe immunocompromised patient, regardless of their vaccine status, can qualify for monoclonal antibodies. So this is an asymptomatic patient who tests positive and they're maybe receiving chemotherapy, or they have some of the biologic agents for Crohn's disease or for some rheumatologic illness. They can qualify for monoclonal antibodies early on. And then there's also a population where if they're unvaccinated, plus they need one of these conditions. So if they're unvaccinated and obese, they're unvaccinated and have chronic kidney or liver disease or any of these other kind of conditions, they can receive monoclonal antibodies. And the data on monoclonal antibodies is that it does reduce need for hospitalization quite a bit. This has kind of been a game changer in adult populations, particularly those over 65 who are more ill than usually our childhood population is. There are a couple different sites in New Jersey that are giving it to children, and there's an availability of referring patients if you have somebody that you think would qualify for monoclonal antibody therapy. There was a moment in time where we really were short on monoclonal antibodies and it was being restricted. The reason for that is there's currently only 2 on the market that are really effective against Omicron. And as Omicron had its height, there was a smaller number of patients who could qualify. So there were like 3 different things that you had to meet. But this is the current state within New Jersey of who can qualify for monoclonal antibodies. The monoclonal antibodies are obviously only helpful if you get the correct one that's effective against the variant, but we do have 2 in New Jersey, and we have a large supply of 2 in New Jersey that are effective against the current circulating variants. It's kind of a constant process. The Department of Health, along with some of the labs at Rutgers and at Hackensack, are looking at the variants and continuing to kind of communicate that with people using the monoclonal antibodies. So that's my basics on acute COVID-19, kind of what we're seeing, what we're looking for, and what treatments are available. We'll shift gears slightly, and we're going to talk about multisystem inflammatory syndrome in children. This is where a lot of our significant morbidity and mortality was actually seen for patients under the age of 18. There have been 195 total cases in New Jersey. There's been 1 death. This was very early on. I think the patient died in like April of 2020, before we really knew what we were doing with MISC. Essex County has had 32 confirmed cases, and this is not just patients who were treated in Essex County. These are actual Essex County children. And the largest peak in MISC cases was in the first wave back in April and May of 2020. What's really fascinating about this and why I like this chart, this came directly from the NJ DOH COVID dashboard, is that there is a male predominance. And then if you look here also, the race and ethnicity breakdown is not consistent with the race and ethnicity breakdown of 1, infections, and 2, New Jersey in general. So the Black and Hispanic populations are at larger risk for MISC, and we're not 100% certain why. There's still a lot of studies, a lot of questions that we haven't answered, but the Black and Hispanic populations tend to be affected by MISC a little bit more than the other populations. And then about 1/3 will be white. The other interesting thing, and for those who have taken care of patients with Kawasaki disease, that's what it was always compared to, was this is Kawasaki disease. It's some sort of an inflammatory illness that's triggered by a virus. And in Kawasaki disease, the shift of the population is that it's usually in children under 3. Here with MISC, it was much more predominant in those over 5. So it's an older population having this brisk immune response to the infection by COVID-19. Here's the clinical criteria. This comes right from the CDC. So it's subjective or documented fever for 24 hours prior to hospitalization, or if they come into the hospital and they have for the first 3 days, like within the first 3 days of hospitalization. And then they need at least 3 of the following clinical criteria, or these can kind of present themselves during the criteria. Again, this is a very wordy slide, but another thing that you can refer back to. So the primary clinical criteria is it's fever plus if they've got severe cardiac illness, which includes myocarditis or pericarditis, and left ventricular dysfunction. And then if they have a rash and non-purulent conjunctivitis. So one of these two. And then with secondary clinical criteria, this is they need a few more of these. So one primary or three secondary criteria. So new onset neurologic signs and symptoms. Typically what we're seeing with that is neck pain, headaches, or confusion. Shock or hypotension not attributable to medical therapy. So this means that someone who's getting dialysis who goes into shock, they're not necessarily the same as just this patient who comes in shock. And very, very commonly abdominal pain, vomiting, or diarrhea. And then thrombocytopenia is exquisitely common. So that's what we're generally seeing is patients will come in, they've had a fever for a couple of days. Mom says they start to get more confused. They're much less active than usual, a lot of vomiting and shock. And that's kind of what's meeting the MISC clinical criteria. Then they do need laboratory evidence of SARS-CoV-2 infection. This is a little bit easier now, but it's also becoming a little bit trickier, right? So back in April and May of 2020, very often we didn't have, the laboratory evidence of the SARS-CoV-2 infection. Now we can get an exposure, but what we're also finding is incidentally, a lot of patients are positive for antibodies, right? So trying to figure out, are their antibodies old or new is a really kind of tricky piece of this. And that's where your suspicion is important. So if everybody in their classroom had COVID, 2 weeks ago, and now the patient's coming in with this is something that you're going to be kind of concerned about. And then they're also going to have elevated levels of C-reactive protein, ferritin, IL-6, ESR, procalcitonin. And some sort of positive SARS-CoV-2 test. So for those of you who are, outpatient doctors or who work in schools, what you're really looking for is that patient who has a fever and also kind of some of these other features, a fever and headache, for example, or a fever and abdominal pain, vomiting, and diarrhea. The tricky part is, right, as everyone has noticed, since masks are coming off, schools are kind of going a little bit back toward what we used to think is normal. You're also getting a lot of patients with gastroenteritis, right? And how do you tell the difference between somebody with just gastro or if they have MISC? And I think that, for those of you who work in schools, referring them to their pediatrician is super important just to kind of get them seen and evaluated. And for the physicians, it's really important to kind of think about labs. If it's been 24 hours, their diarrhea and vomiting resolves, their fever's gone, I wouldn't worry so much about it. But if they're really not behaving the way that you would expect a normal gastroenteritis to present, then that's what you're concerned about. I will say in my experience, and I've probably treated about 50 kids with MISC, it's not subtle. Their abdominal pain is not normal abdominal pain. It is really severe. They can't keep anything down and they just are not behaving normally. It's not kind of this like, oh, you might have it, you might not. The Kawasaki-like illness, where they just have a rash, maybe some conjunctivitis and, some sore throat, that's a little trickier, but that might be the patient that you were concerned about Kawasaki disease to begin with, and you might watch and kind of send them in. The earlier the treatment, the better, but you do have 24 to 48 hours to kind of sort out, is this just a normal childhood illness or are they getting worse? In terms of treatments for MISC, there are a lot, and the CDC has like a guidance in treatments, and generally what people are using is you start with an anti-inflammatory agent, and the first line anti-inflammatory agents that are being used for MISC are IVIG and steroids. The steroid dose is dependent on the patient's status, meaning someone who's in the ICU or in shock might get a higher dose of steroids than somebody who's just on the floor who looks pretty well. IVIG and steroids are always used together. We're not using IVIG alone. Some centers and some patients qualify for steroids alone. They're doing very well. If they don't have large cardiac involvement, you can just use steroids. But unlike Kawasaki disease, IVIG alone does not seem as effective in reducing the inflammation associated with MISC. So there is a thought that this is actually a totally separate pathophysiology. And again, there's a lot of studies out there that are looking at the biomechanisms of how this is happening. We use thromboembolic prophylaxis. The reason for this is in the early studies through Boston Children, through the CDC, we participated, and actually quite a few centers in New Jersey participated in one of the large cohort studies. And about a third of the patients ended up with clots, which is really high for children to have a third getting clots. So early on, they start with aspirin, and it's not just the anti-inflammatory. This is actually to prevent clots. And then those in the ICU or with clotting risk factors, you're actually going to start them on a Lovenox or heparin. The second line treatments are going to be anakinra, which is an IL-6 agent, and infliximab, which is a biologic agent that actually acts on the cytokine storm itself. But starting with IVIG and steroids, patients generally have good outcomes. The real key to it is if you're in the community and you're trying to decide where am I sending this patient, you want to send them to a facility where pediatric cardiology is available. Pediatric cardiology has been exclusively helpful in treatment of MIS-C because they're the ones helping to detect, at least by echo, the early signs of cardiac disease, and that's a really important part for the patient's outcome. You want to know if there's a rheumatologist available because the rheumatologists tend to be the ones that are helping us to manage these patients, but I wouldn't say that it's a deal breaker. Obviously, if you're going to send them to the emergency room, you're going to send them where you can, but generally it's between the hospital medicine team, rheumatology, and cardiology who are really managing a lot of these patients. Infectious disease is always helpful, but since this is a post-infectious syndrome, they're a little bit less hands-on for this particular illness. The other good thing is that I will tell you that the outcomes have been great. We had our first patient in April of 2020. I saw him last week. He is completely back to normal. He had really severe cardiac illness he was on pressors, he was intubated, he really was very sick, and he's totally back to normal, back on the football team. So kids are really getting better from MIS-C. And I was on a presentation this afternoon with the NJAAP talking about the vaccine for children. And there is some concern about MIS-C, right? And as we kind of take off masks and more kids are getting infected. But the important thing to remember is that this is a very rare disease. Only 195 children in New Jersey have been affected by this disease. So although it's serious and can be severe, it is a rare illness post-infection. So I'm going to switch gears slightly. And again, if you have questions, put them in the chat. I'm happy to answer as we go through. This is kind of just the basics is what I'm trying to get through. So post-acute sequelae of COVID-19, and this is kind of a newer entity that we're seeing and where I spend a lot of my time at this point. Post-acute sequelae of COVID-19 was first described, and we say PASC, you may have heard long haulers, long COVID, there's a lot of different ways to describe it. But this was first described in the adult population in the fall of 2020. Then starting in the late winter, early spring of 2021, children were noted to have similar symptoms. And it's really common symptoms that kind of present either after the infection clears or just never get better. And what I've seen most often is somebody who kind of incidentally tested positive and then something was just off. What we're seeing is fatigue and exercise intolerance, difficulty concentrating. Some will have joint pain and muscle aches. There can be persistent loss of taste and smell, insomnia, and then what's really kind of been noted a lot lately has been behavior changes. Lots of children who maybe before were not problems in class are now having outbursts or having a lot of ADHD that maybe what didn't exist before. Or I've had a couple kids who I've seen who were off of all their ADHD medications, were doing really well, got COVID, and then needed to be back on their medications. In terms of who gets it, we don't know. It's a large area of research, and it does, though, appear that those who are asymptomatic and mildly symptomatic have more significant symptoms. Those who were hospitalized, who had, bad pneumonias, might still have some residual shortness of breath, but these are not the patients who are lasting 6 to 8 months with that. They generally resolve a little bit faster. It's also incidentally associated with mental health disorders prior to COVID infection. So the kid who has always been anxious, maybe their anxiety is exacerbated, or the teenage girl who had some depression before maybe is struggling a little bit more with anxiety and getting back to school. Studies in other countries, this is looking specifically at the UK and Italy, have shown that anywhere from 15 to 48% of children have lingering symptoms 2 months post-infection. So I kind of joke about that 15 to 48%, that's a really helpful range. But what we have really found is that those 2 months post, it's about 20%. And patients who are having it 4 months post, it's probably about 15%. So 15% of kids are still having symptoms in one way, shape, or form 4 months post their infection. And it is starting to kind of really affect schooling. And that's where I know there's a lot of school nurses, a lot of public health officials on the on this webinar, and where you can kind of make that difference of saying, you know, Jenny just is not like herself like she was before. In terms of treatment, the first mainstays of treatment in a lot of these patients is, it is kind of a lot of look back at, are they just out of shape because they've been in front of a computer, they haven't been doing their sports, or are they really kind of profoundly affected by COVID-19? It's impossible to tell the difference, but physical therapy and talk therapy has always been our first line treatment. And we've seen a lot of kids who get back into physical therapy realize that a lot of their joints, aches, and pains are because they've never been out of shape before, right? I won't speak for everyone on the call, but I know that if I don't go running for a couple of weeks, when that first time that I'm out for a long walk, I feel terrible. And most teenagers have never felt this before, right? They've never been out of shape. And so really talking them through physical therapy and getting them to see that it's okay to push themselves is helpful. Talk therapy is exquisitely helpful. What are they anxious about, right? This has been 2 years of full anxiety, and students are and children are kind of picking up on what their parents are worried about, what their parents are anxious about. And they've had, you know, just a lot of that. So getting them into talk therapy is helpful. I do fully recognize the challenge of getting people into talk therapy, and the lack of mental health resources that we have in New Jersey is challenging. We work a lot with our child life therapists in our clinic. We also reach out to, you know, religious organizations, as well as utilizing the, you know, the psychiatry collaborative that's available through the NJAP. There's a lot of different resources to kind of think outside of the box, and speak to your school nurses and counselors as well. What kind of resources do they know about? Because sometimes they know somebody that we didn't know about. I put them back in school right away, even if it's only part-time, and I really speak to the parents that they have to be back there. And sometimes they are saying this, I'm too tired, I can't keep my eyes open through all of school. Great, then you're only going to go for a couple of classes. So this is where I work a lot with the school nurses on how can we safely get them back into school? How can we do part-time? How can we do a little bit of home instruction maybe in the afternoon and get them in the morning, or kind of switching off of classes? But a lot of times I have to be the one to push to say, it's okay if they need to go lay their head down for 5 minutes in between classes or get a little extra time. We have seen a lot of evidence of POTS, which is postural orthostatic tachycardia syndrome. And what I'm finding is that these are children who maybe before had some dizziness or had some history of syncope, and they're really showing vital sign instability. And if I'm being 100% honest, POTS was never something that I 100% understood until I started to kind of treat this post-COVID tachycardia. And I'm seeing it, and I've put a couple of patients on fludrocortisone for a month, and they're completely back to normal, and I'm able to wean them off of their fludrocortisone. So there seems to be something going on where their autonomic nervous system is just a little agitated, and it's a short-term treatment. They're doing a lot of water, a lot of salts, but then also putting them on fludrocortisone shortly for a limited period of time seems to be helping. And then there has been some evidence, and this is, we're doing some work with Johns Hopkins on looking at patients who have a little bit of anxiety, and Lexapro in particular has been shown to be effective in this subset of patients. They have done some studies with brain ultrasounds and carotid ultrasounds looking at blood flow to the brain, and there's actually an increase in blood flow with the patients after Lexapro as compared to before. So again, there's a lot of treatment studies out there, and if you think that your patient has post-acute sequelae of COVID, there are a few centers throughout New Jersey that we're happy to see them and to kind of talk through this treatment. So switching gears slightly, we're going to talk about vaccines in children. Obviously, I know I've got a whole group of very big proponents of vaccines in children, and I'm happy to kind of talk through some of this. So as I was doing this, it was interesting. I got this notification about the US is about to approve a 4th COVID vaccine that they say could be a silver bullet solution to the anti-vax crisis. This is the Novavax, which is not an mRNA vaccine, and it's more effective than Johnson & Johnson. Those of you who are preaching vaccines know that it is not a silver bullet solution to the anti-vax crisis, and it's kind of a funny thing to have as a headline. But these are the headlines that we're kind of working through, right? What is holding up the vaccines for children under 5? And then we're also struggling with, and I don't mean to pick on Florida, but I'm going to pick on Florida a little bit, right? Their Surgeon General is advised against COVID vaccine for kids. How do we compete against all of that, and what is going on? And these are all of the things that your patients are rating, right? I speak with residents often and medical students, and I tell them, you have to get onto USA Today and look at their health section. You have to look at CNN. What is CNN reporting for health? Because that's where your patients are getting their news. And if you don't talk to them about it, then you'll never know what they're kind of reading about and what the misinformation that they're getting may be. So what are mRNA vaccines? Some of you may already know this, as I maybe review for some of you, but just in case. So mRNA vaccines carry genetic material that teaches our cells how to make the spike protein. The spike protein is found on the surface of the SARS-CoV-2 virus. Once the genetic material kind of comes in that teaches our cells how to make it, we destroy that genetic material and it's no longer needed. So it's really gone within a couple of weeks. The mRNA doesn't just kind of stick around and hang out as much as people think it might. Our body then makes antibodies against the spike protein, and it says, this is bad, it doesn't exist, I need to know and attack it. But it does not affect our DNA. mRNA is not able to enter the cell nucleus. This was an important thing as I started to talk to people who were nervous. They thought that their children's DNA was going to become this mRNA. We talked a little bit about, I do talk about biochemistry somewhat to kind of discuss a little bit about this. You don't get COVID-19 from the mRNA vaccine, but I'm assuming most of you on here are vaccinated and are well aware that you feel crummy afterward, right? Your body produces a response. And I have always been a proponent of talking about vaccine response versus vaccine reaction, right? If you get that high fever, if you get that headache, if you get muscle aches, you're actually looking at a great, robust response. And I think that that's kind of a helpful way to shape it. And this technology is new, but it's not unknown. We've looked at mRNA vaccines for influenza, Zika, rabies, and CMV. And so the studies had occurred earlier on these types of technology. We just had all the money and all the people in one spot to move it along for COVID-19. And I think it's actually going to be pretty breakthrough for most of these viruses, right? Our annual flu vaccine, if we can use mRNA technology to really target the variants that are causing problems, I think it's going to be a great way to kind of work through that, particularly as the technology becomes easier to use. So in terms of safety and side effects, obviously the vaccines have been shown to produce side effects, but it's particularly after the second dose. And I think we're all pretty familiar with these at this point, but fever, headache, and muscle aches are going to be far and away the most common. The Moderna vaccine seemed to have a little bit more site pain and site erythema than the Pfizer vaccine did. Really kind of the only difference has been the size of the needle. So there was some thought that maybe a little bit more gets into the subcutaneous tissue from Moderna, but there was some kind of site erythema and tenderness. No significant safety concerns were identified in the clinical trials. And now we have, close to 1.5 years of really robust data. And none of the real significant safety concerns have come up with either Moderna or Pfizer in the VAERS reports in the VSafe, which is the self-reported side effects. And there were some from the Johnson & Johnson, there were some from AstraZeneca. And I think one of the things that I've spoken to patients about is that they pulled them for really small numbers of serious side effects, right? AstraZeneca was stopped in Europe for about 5 cases of clots to begin with. Johnson & Johnson, same thing, it was 5 serious clots. So they are taking it very, very serious that if there is any kind of serious side effect that's coming up in multiple numbers, that they are kind of warning people about them, but it just hasn't been shown. And in previous vaccines, it's very unusual for side effects to appear more than 8 weeks after vaccination. And we have much more than 8 weeks of data at this point. So I think it's important to just talk to parents and to talk to patients that, we do believe that these are safe. They're not maybe as effective as we had thought in the beginning, just with the change in variants, but they are just as effective at preventing serious illness. I work uniquely in the hospital other than my post-COVID clinic. And I have almost never seen a child, I think once, and it was somebody who was immunosuppressed, who was fully vaccinated and was having serious COVID. And, I have not seen anyone who is fully vaccinated and had MIS-C. So these vaccines are exquisitely effective. For those vaccines and those less than 5, and I was speaking with Meg Fisher, who is, on a special advisory to the health commissioner in New Jersey. She's kind of had her finger on the pulse of vaccine studies thus far. So the vaccines in those less than 5, the way that vaccine studies work is they actually look at non-inferiority. So you've got this big population of patients where a vaccine worked, and then they applied to kids. And to give the vaccine in kids, you have to show that it's not inferior to the adult population, so that it's not worse and that it works just as well. Studies have been shown to be safe. There have not been serious side effects in those less than 5. It's just that they're not producing the same amount of antibodies as the adults were. That's really the only reason why everything is held up so much. So for some reason at the dose that they studied, which was the 3 microgram dose, probably a little bit too low. They were trying to graduate it down, but they just did not meet the non-inferiority. They were producing some antibodies, but not that many. So now they're looking at the 3-dose series. And there's been a lot of question as to why did they go to a 3-dose series instead of just studying higher doses in the 2-dose population. And the reason for that is, one, we're looking like adults are all probably should have had a 3-dose series, and that's why we're calling this the booster, you're calling it the extra dose, people are calling it a lot of different things. But also it was a quicker study to just add a 3rd dose to the research population than it was to start completely over with a whole new population of children in a higher dose series. I actually, while I was sitting kind of getting this ready about 5 minutes ago, there was a New York Times headline that said that Moderna has submitted their authorization, their emergency authorization for children. So still 5 and over, but we're going to have another option other than just Pfizer for patients 5 and over. The underage 2 group, interestingly enough, produced great and appropriate antibodies. So we're hopeful that sometime this spring that there will be a vaccine available for children. One thing that I keep telling parents, because everyone keeps saying, well, that apparently they don't work, is I really like the fact that the FDA is really kind of taking a special look at this population, because it reminds us that they didn't take any shortcuts, right? They didn't do anything quickly. They did it quick because we had everyone at the table, we had everyone together. But that they haven't taken any shortcuts, they haven't cut any corners, and we really should be satisfied with the fact that this is going to work well in our kids and that it's going to be safe. And that's kind of been my takeaway from this kind of large delay. And I think they were also, satisfied with the fact that children less than 5 were really very rarely being admitted to the hospital. It's not 0, but rarely. So we do have a little bit of time to kind of work with them and to make sure that they are well protected when we give them the vaccine. So this is where we're at right now with COVID vaccine in New Jersey. So about 80% of the population has received at least 1 dose in New Jersey. It's actually really good. But for ages 5 to 11, only 35% of the population in New Jersey has been vaccinated. So we're really not doing great for the 5 to 11 population. What I found really fascinating is once you get above 12, 71% of the population has been vaccinated. So for the 5 to 12 to 17 population, it's really a high number. I think part of that is assisted by colleges were requiring it, certain schools were requiring it, to go to a sporting event, people were requiring it. But that 12 to 17 population, really, we've done a great job. But this 5 to 11, only 35%. So we have a lot of work to do to get people vaccinated. And a lot of that is to talk about, how safe they are. We have about 588,000 fully vaccinated people in New Jersey. That's great. And if you look at the kind of spread of who's been vaccinated, we still have work to do in the Black and Hispanic population, but it is much better than what it was in the beginning. And we really made a lot of inroads in that population as well. Here are the benefits for every 1 million Pfizer doses given. So the reason why we're looking at Pfizer is because it was the one that was approved for 5 to 11. So recently, this is like within the Omicron era, 58,000 COVID cases were prevented, 226 hospitalizations were prevented, and 132 MIS-C cases were prevented. Also, 72 ICU admissions were prevented for every million Pfizer doses given. So this is actually really great, and I like to see this MIS-C because that seems to be what people are afraid of. If you look at the pandemic average, the numbers go down slightly, but that's just because of the numbers. When you look back, it's prevented close to 20,000 COVID cases, 80 hospitalizations, 42 MIS-C cases, and 26 ICU admissions. So this is looking specifically at epidemiologic data to kind of talk through how are the vaccines working, what are they doing, and it is safe and it is helpful. So kind of shifting gears slightly, so that's the vaccine. I'm again happy to answer a few more questions as we go on. I'm going to shift slightly and go into COVID in schools. So there is guidance for schools. Again, a very, very wordy slide. This is for your reference later. But the NJDOH and the AAP have updated guidelines every 90 days. That's their rule. They're looking every 90 days. If something happens, like for example, the mask mandate, right, was lifted for March 7th, both the NJDOH and the AAP, because many states across the country were lifting mandates around the same time. So if you look on the NJDOH website, their most recent guidelines for schools were updated February 22nd with masking optional in mind. There are times when masking should occur. So what they did is they took it away from a state decision and made it, kind of area by area. And that does make sense because Northern New Jersey seemed to originally have a harder time with COVID-19, and then it shifted towards South Jersey. And now we're kind of in like a little bit of a leveling off period. But during periods of elevated community transmission, masking should occur if you've got an active outbreak in your school, or if you've got a patient returning from isolation or quarantine. And then if a school or staff member, if a student or staff member becomes ill, they should mask while they're waiting to leave. And then if you're utilizing test to stay, they should also mask during that time post an exposure. So there is a CALI score of, which is the COVID activity level index. You can get that from the NJDOH to kind of help to decide, is it important to mask or not? For return to sports, the AAP actually updated their recommendations February 18th. And they're really focusing a lot on the fact that we've seen an increase in obesity. We've seen an increase in children who just haven't done anything for 2 years. So they're talking, how do we encourage physical activity? And a lot of kids' physical activity occurs in schools, sports and gym, right? And so how can we encourage physical activity and make it important and safe? Early in the pandemic, the thought of myocarditis post-infection, and this was like you get the infection, you have myocarditis shortly thereafter, was thought to be up to 5%. So early on in the pandemic, they said anyone who has COVID-19 should have an evaluation for myocarditis so that we can prevent cardiac death. Now the incidence, as we've kind of seen more and more, is really closer to like 0.3%. So myocarditis post-infection is really not as much of a player as we thought it was. So any child who tests positive for COVID-19 should notify their pediatrician. It does not have to be a visit. And I know very much that this is sometimes overwhelming, but like a phone call to the doctor that just says, hey, my kid had tested positive for COVID on a home test, you can mark it down. For those who were asymptomatic or mildly symptomatic, they should have like a phone or telemedicine, something just to say, do you have any shortness of breath? Do you have any chest pain? If not, then they can go right back to their activity. As soon as they're out of their isolation period, they can go right back to activity, provided that they don't have any of these symptoms. So every practice, I think, probably has a bigger challenge and different challenges on how you're going to do this. Is it going to be a phone? Does it need to be the doctor who's assessing these questions? Can the school nurse kind of have the question and make sure that their school doctor says okay? And I think that that's kind of a logistical challenge that I recognize. But you should have somebody just make sure that they're not having any chest pain, shortness of breath out of proportion, or new onset palpitations. And then you're going to talk to them a little bit about proper isolation. For those with moderate symptoms, and the moderate symptoms are here, higher fevers, more days of fevers, if they needed to be in the hospital, then they should actually be seen by their primary care doctor. There is the American Heart Association 14-element screening evaluation. It talks about cardiac symptoms, and you can kind of check through that if they've had moderate infection. And then if you can get them an EKG, that's the ideal situation. If they really have no symptoms, they were admitted for diarrhea, they were admitted for gastroenteritis, and they have no cardiac symptoms, you actually can skip the EKG. But if they were there for pneumonia, you probably want to grab an EKG. And if the cardiac workup is negative, you can do gradual return to physical activity. And what gradual return to physical activity is kind of a controversial question, but it's really what can the child handle? So maybe don't go out and run your full cross country race the first time, but go try doing some walking and seeing how you're feeling. For children and adolescents who have severe COVID symptoms or MISC, they really should be restricted from exercise for 3 to 6 months. And MISC, I know, is in 2 places, right? And it says no evidence of MISC, but if they had like moderate and no cardiac illness, you really just want them to be cleared by their cardiologist. So it's generally going to be with MISC or with severe COVID, they should be restricted from exercise for 3 to 6 months. And they should see a cardiologist to determine when they can resume activity. And the reason for that length of kind of increase there is that the length of staying out is really, you just want to prevent the heart damage that can and sudden death. Early on in the pandemic, there were a couple of college athletes who had been probably more severe than they admitted, who then started to play. There was one kind of big one from the University of Florida, who was a, big time basketball recruit looking at the NBA, and he collapsed on the floor, and it was all post-COVID. So just kind of having them cleared early if they have severe illness. This is, again, just to kind of, because I knew you guys were going to get these slides, this is a good kind of look at who needs a referral, who doesn't, who can be cleared to play and who cannot. So this is a good place to refer back to. It's also on the AAP's website, and the NJDOH has something similar, but I think this is just kind of a nice little algorithm of who needs to see whom. So that's what I have. I am happy to answer questions. I know I went through a lot of things pretty quickly, but I wanted to make sure to kind of cover some big things. So are there questions?
Thank you so much, Dr. Klauser. I will unmute participants too, or you can put questions in the chat if you'd like. I do have one question myself while I'm in the process of unmuting people is I know early on in the pandemic, some pediatricians were recommending supplementing with vitamin D because low vitamin D levels were thought to be associated with more severe COVID in children. So I was just wondering, like, has there been more research on that? Is that still something that's getting recommended? Is that something that's associated with lower MISC levels?
That's a great question. And the short answer is the jury's out. So vitamin D is never bad. And when I was a resident, Dr. Schwab and I actually did a research study looking at vitamin D levels, and our patients in our clinic, 88% of them were vitamin D deficient. So I think that the idea that vitamin D deficiency led to more serious disease is just because lots of populations are vitamin D deficient. So it's never a bad thing. And that's kind of what I've been recommending. If you feel like it makes you feel better and it's, taking a little vitamin D and zinc is probably not going to impact anything negatively, provided that you're not taking too much. There are side effects to taking too much vitamin D, but as long as you're not. So the jury is still out, and there's still kind of some looks at randomized controlled trials, but nothing definitive has been decided at this point. But vitamin D, zinc, and vitamin C are probably not ever going to hurt anybody.
I had a question about surveillance. So now that we have a lot of in-home testing being done, you mentioned people calling the doctor and asking them to note the test down in their record, but is there any way to collect this data, and is it going to affect really what we know about the next wave with a lot of the home testing that's going on? And how should it be followed up by those of us who are doing in-office testing?
It's a good question. I had a meeting with the DOH not so long ago, because their request is that if somebody has a positive home test, that you call your local DOH and report it. And then it can actually be kind of collected. I think that moving forward, the general kind of prevalence of infection is going to be far undercounted. And I think it is going to affect how we understand things. What we're hoping for is the CDC has a large grant looking at patients who are either not having, like we're actually doing a PASC study looking at patients who were infected and who were not. And we're hoping that we're able to kind of get a little bit more of an understanding, because these are where you tested at home. We're going to look at antibody levels. And so I think there will be a way to survey it as well. In terms of follow-up, if you're doing in-office testing, if you're, letting the family know and having that discussion of, isolation is really, really important, and making sure that they're kind of making the right decision. So isolation currently is 5 days at a minimum and 24 hours without symptoms, except for they can still have a little bit of fatigue and they can still have loss of taste and smell, because those can persist a little bit longer. If you're doing in-office testing and it's a point of care, there is ways that you can report that to the DOH, and I can get that information out to you guys. I don't know off the top of my head exactly where you can report it, but there is a way that's like a little easier to say we had 5 patients tested today, or even just our rate of positivity was whatever it is. I understand it puts a lot of burden on people doing in-office testing, right? If it's not going to a lab, like doing one more reporting is really tough. And the goal is to try to get as much information as we can.
I have a question. We are seeing more common cold in kids now. And so I'm just wondering about your recommendation in terms of managing the testing, and because it's the all stress that, there are similar symptoms as COVID, and then we have to test, and for this and for that, and PCR, and it seems like kids are missing school days because you have to wait for the result and send it to school in order for them to attend the school. Do you have any recommendations around, and if you've seen, a lot of kids now, especially with not using masks, just experiencing common cold symptoms during this time?
Yeah, it's tricky. And I will say that currently on our pediatric floor, we're full here up at Hackensack, and we have not one case of COVID, but we have a lot of old coronavirus, right? What I have, all my residents keep calling it OG coronavirus. They're much cooler than I am, but the original thing, or RSV, is still sticking around a little bit longer. Flu is a big deal. I think that utilizing the rapid tests as much as school districts and schools will accept that is going to be really helpful to reduce the burden. The other thing is that kids probably should have been home with these viruses for 24 hours anyway, long before any of this. And I think that if we can keep them home for that 24 hours, it's probably a built-in thing. But generally, the way that we're kind of approaching testing within the hospital is if they're symptomatic, they're going to get a full respiratory panel, and that's just for our isolation. I think as an outpatient doctor, allowing them to do a home rapid COVID test just for the sake of the parent's job probably needs it, the school probably needs it, but then pursuing further testing is not as important. But I think that the rapid test in a symptomatic patient who doesn't have a ton of exposure is really helpful and probably the way to go. And I think that that's the move that most of the departments of health are talking about, is doing more of the rapid testing.
Thank you.
Mm-hmm.
Dr. Klauser, I have some friends who have recently started having their young children under 5 tested for COVID antibodies. And under, their pediatrician recommended that they could, and so now they've been shown that their child has COVID antibodies. So I'm kind of thinking ahead to, when the vaccination is approved for that group, and that may make it that parent less likely to want to get their child vaccinated because they may think my child's already protected, or maybe behavior changes, right? And so I guess I'm just wondering, do you have any thoughts about that, pediatricians having that under 5 group tested for antibodies, and like what that means for vaccination?
Yeah, that's a great question. And I think that the role of natural immunity in all of this is really nebulous and nobody knows. We do know that natural immunity is going to wane at some point, right? We know that. We've seen it. People who are infected early on were then at risk for other variants. There's a lot of people who have been repeat infected and maybe had worse symptoms the second time than the first time. So natural immunity is still a large area of research. And I think that physicians who are getting children tested for antibodies are probably doing so with a good intention of like, let's give the parent a little bit of peace of mind. Your child has a little bit of protection. They've got antibodies. But what we do know is those antibodies are eventually going to wane off. What we also know is in a lot of studies, and particularly Israel looked a lot at natural immunity and then natural immunity plus vaccine. And natural immunity plus vaccine was far and away the best way to have longer lasting protection, because that vaccine is going to boost the natural immunity that you already have, and it's just going to protect you even more. So for peace of mind for parents, what I would recommend is that, kids are not showing huge behavior changes post their vaccine, and that we are not seeing, the bad kind of reactions from children. Children are actually handling it much better than most adults, honestly. Like they get their 12 hours of a little bit of pain and then they move on and it's fine. Kids are used to vaccines. But kind of doing both is the best way to protect them from longer term side effects. The other kind of interesting thing is people keep telling me, well, we don't know what the side effects of the vaccine are, but we do know the side effects of getting COVID-19 and long COVID, MIS-C, all of those are not small things to think about. And so taking, weighing both, we know one has a side effect. Meaning getting COVID, you can get long COVID, you can get MIS-C, and the vaccine, we're just really not seeing a ton of long-term side effects. So, kind of helping them to weigh that idea. But with antibodies, getting a vaccine is really going to boost that antibody level.
Thank you. Are there any other questions for Dr. Klauser?
I can just ask one. Thank you, Dr. Klauser. I like how you mentioned vaccine response rather than reaction and thinking of it that way, and how having a strong vaccine response is actually a good sign. Is it a negative sign if there's very little vaccine response?
So no is kind of my shorter answer. I actually had no side effects, and I use myself as an example. I had no side effects, not a fever, not pain, absolutely not, like to the point that I was like, maybe I got the placebo somehow, even though, whatever, they gave me the wrong thing. And I had antibodies tested in December, still had antibodies and was never infected by COVID, never had signs and symptoms of COVID. It's just your body. So it's not necessarily a bad sign. It just means that your body handles things a little bit differently than somebody else's. Yeah. Just looking at the chat here and it doesn't seem like some.
Dr. Klauser, hi, this is Iris Cooney from Horizon Blue Cross Blue Shield. I just wanted to thank you for the talk, and the flip side of that, some folks that got vaccinated, no reaction, no symptoms, normally went about their business. The other side of that is for folks to really do follow up with their PCP when they do have side effects, right? Whether you're fully vaccinated, boosted, if you're still showing symptoms, it's important for the research and for appropriate services rendered and treatment planning for folks to report the side effects, and to go back and follow up, even though it's tedious and cumbersome, but to really design treatment plans accordingly, especially in minority groups. I adversely fully vaxxed, boosted, but I do have a pre-existing condition, and I did not fare well, during the last surge. So again, just promoting folks to not only get vaccinated and boosted, but to follow up with their PCP.
Absolutely. I think that's so valuable, because I think also, one of the things that we've been battling as healthcare providers is there's just this idea of like, if you at all say anything about, it hurt me a little longer, I had a fever for a little bit longer, that it somehow makes us, if we're entertaining that you're somehow anti-vax, and that's not it at all, but recognizing what are the side effects that people can experience. because some people will actually, you know, may have fever for 3 days, and it would be really nice for me to be able to tell somebody, you could have fever for up to 3 days. That's totally normal, and that's really helpful. I also encourage people to talk to your patients about doing the vSafe app. I, by accident, after my second dose, hit a box that I had been hospitalized, and I got a phone call within 22 minutes. And, you know, it was like they wanted to check, why was I hospitalized, what happened? And it was because I had in error submitted something. So there are people watching that, there are people looking at it. And then I do encourage physicians to go into VSAS, and VSAS is the vaccine safety reporting system. I'm sorry, VAERS, vaccine safety reporting system, adverse events, and it stands for adverse effects with vaccines, whichever knows. That existed prior to COVID-19. You could do it for any vaccine, and the more information that you have is helpful. What the problem with VAERS has been thus far is that some people who didn't want to do the vaccine have been putting in false reports. And so what it does is, if we're not putting in the real reports, then the false reports end up carrying more weight, but also become so that people aren't thinking that it's real and it's a whole thing. And so make sure that you're using the reporting techniques that you have so that we can really get all the information and give that to populations. People want to know the truth. They want to know what's going on. And if we can say to them, listen, I've treated a couple of people who had side effects. I've treated a couple of people who were fully boosted and ended up in the hospital with COVID, you know, whatever that truth may be, I think it's really important.
Exactly. Thank you.
Great. Thank you so much, Dr. Klauser. We really appreciate your presentation today, and I learned a lot. And I would like to remind everyone to please fill out your evaluation form. You know, there's a link in the chat because if we are offering nursing credits for today's program. So thank you again so much, Dr. Klauser. Really appreciate it.
Thank you for having me. I look forward to the day when I'll come back and talk to you about something that's not COVID.
Okay, yeah, I'd like to add my thanks as well. I guess we'll move on now to the business portion of our meeting. And first of all, the first order of business is the approval of the minutes from last quarter. So I think everyone should have received those in their email packet, an invitation. Does anyone have any questions, comments, or corrections regarding those minutes? And you can put those in the chat, or I think people are still unmuted, Emily.
Yes, everybody can unmute themselves at this point. And I posted the December meeting minutes in the chat as well as a document.
And if there are no corrections or additions to be made, I will accept a motion to accept the minutes as is, and you can vote in the chat as well as we go forward.
I motion to approve the minutes.
Thank you. And do we have a second?
I can second.
Thank you. Okay, so you can please just place your vote, yes or no, into the chat, and we'll count that up before the end of the meeting. Okay, so then while that's going on, I think, Emily, maybe you can move on to the working group updates, please.
Sure. So I'll start with the education working group. For those of you that don't know, our Essex Metro Immunization Coalition has 2 working groups that meet in between our quarterly education meetings to talk about what's going on in the community around immunizations and plan initiatives and projects with our EMEC partners to collaborate. So our education group, a community education group met in March to discuss resources on COVID-19 information that are available, including some online virtual sessions. And we also discussed, some of the members of the education group are working together to talk about some COVID-19 community clinics at faith-based organizations. So they're reaching out to some connections at faith-based organizations to host a COVID-19 vaccination clinic, and they're in those planning stages now. Some of the partnership programs have also hosted live sessions on social media on different topics, COVID-19, health equity, and human papillomavirus for HPV Awareness Day in March. So if you'd like, you can view those sessions. They were recorded and they're on the Instagram accounts. So the COVID-19 and health equity accounts are posted on the Step Up Backs Up Instagram, and those are that's with the College Health Initiative program and the Step Up Backs Up contest. I also posted a flyer for that contest in the chat. The submissions are open through April 1st, so we still have 1 week left where students could submit, and that does have a $5,000 grand prize for the top student submission, and that's open to all New Jersey college and university students, undergrad and graduate. So if you know any college students that maybe have not yet heard about Step Up Backs Up, please let them know they still have 1 week to create a video or digital creation and submit that for a chance to win $5,000. And the HPV awareness session can be viewed on the Essex Metro Immunization Coalition Instagram account. The working group for community engagement met in February, and this group discussed ways that we can work with pediatric providers in Essex County to utilize NJIIS, the New Jersey Immunization Information System, to encourage those pediatric and family practice providers to increase routine immunization coverage. And how do we work together with pediatric and family practice offices to encourage the use of NJIS tools in looking at routine immunization rates. We also are working on engaging current EMIC members in activities for April's Infant Immunization Awareness Week by partnering with some of our coalition members in the Essex metropolitan area to provide infant and early childhood immunization education to early childhood centers, YMCAs, and Head Start centers in our service area. So that's what the working groups have been up to since our last meeting. If you're interested in joining the working groups, we do host quarterly calls in between our meetings, and you're welcome to participate. You can contact me. I'll put my information in the chat, and we'd be happy to have you join us and collaborate with us on some of these community events.
All right, thanks, Emily. Just a reminder to place your vote in the chat. And then is Dr. Sharp on? Cool.
I don't think she was able to join today.
Okay, so then I'll take over, and I'd like to invite anybody, any of our members from EMIC. Thank you all for joining us. And if you have anyone has any updates that you'd like to share from your own organizations of activities going on or successes that you've had over the last quarter, please feel free to share those now. I see Antoinette has her hand raised. You can unmute and talk, please.
Hi, Dr. Sharp. I just wanted to remind people that Public Health Week is coming up in April, as Emily was saying, when the competition ends. So I'm not sure if the partnership or the various agencies represented here today, but certainly the New Jersey Public Health Association is encouraging everyone to, at least for the Public Health Week, to post "This is Public Health" on there, or what public health means to them. Public Health Week is the 4th to the 10th of April. So we encourage you, and also, of course, shameless plug, if After this, you can find New Jersey Public Health Association on Facebook, because we're having the schools. We're also getting all the schools, undergrad and postgrad, involved in what public health means to them. Particularly in light of COVID, everybody should be more aware and be more enversed of how to intertwine the public health thing. That's my sharing for today.
Thank you.
Thank you, Antoinette. Is there any particular like hashtag or anything that you would encourage people to use when they post that what public health means to them post?
Literally the hashtag, this is public health.
Thank you.
Would anybody else like to speak? Okay. So if not,
Dr. Shah, I'm
yes.
sorry, I just wanted to remind folks, even though we're still under the public health emergency, for Medicaid eligible individuals to please remind them to renew if they receive something from the state in order to maintain their Medicaid coverage and be in good standing through the state. Please remind them to renew their coverage. So when they do need care, their Medicaid coverage is still in place.
Thank you. Well, we're right up about our 3:45 ending time. So I'd encourage all of you, if you do have updates to share, please send them to Emily by email, and we'll include them in the newsletter as well. And we're looking forward to seeing everybody at our next meeting next quarter. So the details of that will be sent out as well. And thank you all for joining us, and hope you really got something out of the speaker's talk. I know I did today. It was very enlightening and engaging. And thanks again, and be in touch over the next few months.
Thank you.
Thank you.
Have a good day.
Bye, everyone.
Thanks.
Thank you.